Good afternoon, everyone. I have the pleasure of introducing our next speaker, Dr. Roston, who's a cardiologist at UBC with a clinical and research interest in all forms of genetic heart disease.
I knew that we would be running behind schedule, so I wrote a one-sentence biography. And to not contribute to the problem of the day, I've set myself my own timer and already deducted 1 minute from it. So my main objectives, other than being on time, is to talk a little bit about HCM, what we think the mechanism of it is, and then talk about this novel class of drugs called myosin inhibitors. So I'll give you a typical case that most of us who work in the HCM clinic will see, at least once a week. And this is a 42-year-old male who had progressive loss of exercise tolerance. He has some mild cardiovascular risk factors, but he has significant obstructive HCM when he exercises in particular. He started on long-acting metoprolol, but he's entirely intolerant to disopyramide, as many people are, because you get a lot of anticholinergic side effects. And within 8 years, he becomes completely sedentary. It's mostly self-induced because he can't do very much, and this leads to severe obesity and overt diabetes. And throughout this time, his serial echocardiograms have always shown that he has a significant LV outflow tract gradient when he exercises. So he decides to enroll in the clinical trial because he prefers not to undergo surgery, which is really the only other great option for this individual. So just some very basic things, because I know not everybody in the room, especially related to EP, manages a lot of HCM, and many of our patient partners may not have much familiarity with it. So HCM is a phenotypically diverse disease. You can have many different LV shapes. So the classic one is the one you see on the left there, which is a sigmoid septum, where you get severe obstructive symptoms often, where not enough blood can be ejected out of the LV cavity into the aorta. But there are other types as well, and we're mostly going to talk about the obstructive type. And about 40% of patients, give or take, have a pathogenic mutation in one of the sarcomere genes. So 2/3 have this issue with obstructive physiology, where when they exercise in particular, they often get quite significant symptoms. And one thing I really want to point out, and I think it's very much the theme of our day today, is that if you went to an HCM meeting 10 or 20 years ago, they'd be talking about things like disopyramide, verapamil, beta blockers, alcohol septal ablation. And while all of these have been really important advancements, they've all been actually supported by, at least from a guideline perspective, at best, moderate quality evidence. So none of these studies were randomized trials, meaning one individual in the study got the treatment and the other one didn't. None of them were blinded. They're all observational. And I think this was very much the theme of our field up until a couple of years ago, when we started to become a lot more rigorous about evaluating new therapies with better study designs. And HCM is a great example of this because it's not quite as rare as some of the syndromes we've talked about today. And with a prevalence about 1 in 500, you really can do fairly sizable randomized trials. And so we're going to talk about a couple of the really great emerging molecules that have been studied in this manner. So I'll skip over this a little bit in the interest of time, but just to realize HCM is one of the first genetic discoveries in terms of the cause of a disease in the 1980s by the Simon family, which is really, or the Seidmans, which is really a great story of a very large Boston family. And I'd also be remiss not to always quote Dr. Tadros' excellent papers. And I think what's important, we've talked a lot about dilated cardiomyopathies already, or non-ischemic cardiomyopathies. And what his work has really helped show us is that these are really opposite conditions. One where you get way too much hypertrophy and one where you get way too much thinning and dilation. And they're really opposite genetic problems as well when you look at Mendelian randomization studies. And so Rafik is really probably a world leader in the polygenic basis of HCM, which I'm sure he'll tell us about later today. So this is a disease predominantly of the sarcomere, where during the off state you have an excessive number of actin-myosin cross bridges, and this leads to hypercontractility and abnormal diastology. And so the first class of drugs I want to talk about, which are the myosin inhibitors, are really a novel therapy that targets this etiologic mechanism of disease. So before, we give patients beta blockers and calcium channel blockers, and they were negative inotropes, meaning they made the heart beat less vigorously, but they didn't actually target the molecular cause of the disease. And this is what these two drugs, mavacamten and aficamten, have tremendous promise in. So first, there was a preclinical study in 2016. We've seen a lot of great preclinical studies today. They form the basis for these larger trials. And the first study, which many of you have heard about by now because it's now been out for a few years, is the Explorer-HCM study. It was published in The Lancet in 2020. And this was a randomized placebo-controlled trial of symptomatic patients with obstructive HCM. And mavacamten is a drug that basically every month for the first 3 months you're on it, you do an echocardiogram, you remeasure their level of obstruction, you remeasure their EF, and you redose the drug. And then patients need echocardiograms every 3 months thereafter for monitoring. And they used a combined endpoint in this study looking at basically improvements in functional status and peak oxygen consumption. And it was a pretty typical HCM cohort, so middle to advanced ages mostly, with quite a bit of obstruction despite being on guideline-directed therapy. And to make a long story short, it was a rather positive trial, which was very promising, which led to the approval of this medication, first in the United States and now in Canada. And we've had it in Canada for a little over a year now. What you can see is that by week 4, patients randomized to mavacamten already had significant improvements in the alveolar outflow tract obstruction, and a significant improvement in many patients in their NYHA class, so improved symptoms of shortness of breath. One thing that's really important to remember is that mavacamten is a negative inotrope, so it makes the heart beat less vigorously. So one of the side effects is giving too much mavacamten, particularly depending on how you metabolize the drug, can induce LV systolic dysfunction. And so these patients do need rigorous echo follow-up. And that really can be a huge issue for a lot of our patients, especially those who live remotely, to get these echocardiograms on a regular basis. But so far, we've been able to mitigate that fairly well. So next, I'm going to move on to SEQUOIA-HCM, which maybe many of us have not heard much about yet, because this was only just published in the New England Journal of Medicine last month. So this is a different type of myosin inhibitor, and I'll explain a little bit how it's different in a sec. But the design of this trial was very similar to Explorer-HCM, in fact, almost identical. So it was a 24-week double-blind randomized controlled trial. But what's interesting about this drug, aficamten, is it's got a very short half-life compared to mavacamten, which allows you to increase the dose more rapidly. So these patients actually had dose escalations based on their echo at 2, 4, and 6 weeks instead of 4, 8, and 12 weeks, which was how it worked with mavacamten. Their primary endpoint was actually just peak oxygen consumption, so quite an objective measure of improvement as opposed to a combined symptom-based outcome. And they had a very similar size population and very similar demographics. So as you can see here, the patients who were randomized to aficamten by the end of the study had significant improvements in their oxygen uptake and their peak oxygen, their change in oxygen uptake and their peak oxygen uptake, and significant improvement in their NYHA class as well. And you can see on the right there, when they wash the drug out, people's symptoms actually return after stopping it. And this is, again, similar to the other figure I showed for mavacamten, significant improvement in LV outflow tract obstruction. And in this drug, really within 2 to 4 weeks, you start to see the effect because you're able to more rapidly increase the dose in individuals because of its short half-life. And again, importantly, looking at the washout period, once you come off the drug, you kind of go back to the way you were before. So just comparing Explorer to Sequoia. So one is mavacamten, one's aficamten, similar sort of dose ranges. Aficamten is not yet approved, but likely will be, I've heard, by the end of the year. The Explorer study used a co-primary endpoint, whereas Sequoia used a primary endpoint just looking at peak VO2. This is a slowly titratable drug in Explorer and a more rapidly titratable drug in Sequoia. There are several important drug interactions with mavacamten, but one thing that's nice about aficamten is really very few drug interactions. And there is some early thought that there may be some differences in efficacy of these two drugs. It's a little hard to compare head-to-head, but the peak VO2 increase was a little higher in the Sequoia study, and there's maybe the thought that there's less attenuation of benefit in people on high-dose beta blockers, which was a concern with mavacamten. So there's very similar drugs, similar class, and it'll be interesting to see, in 5 or 10 years, which one we're using more often, and if there's more myosin inhibitors that will come down the road that are even better than these two. So I tell patients it's the rule of thirds in these two studies. So about 1/3 of patients will get dramatically better on a myosin inhibitor, about 1/3 will get a little bit better, and about 1/3 have no response. And there's a nice study, which I won't talk about now just in the interest of time, called VANISH, that looked at mavacamten in people who would go on to have surgery to relieve their obstruction. And if they got mavacamten first, a significant number of patients actually did not require surgery. So it probably mitigates the need for invasive therapies in this condition. So MAVERICK-HCM is also another study that looks at non-obstructive HCM. So people who have symptoms like dyspnea due to diastolic dysfunction but don't have obstruction. In this small phase 2 trial, it seemed like some of the markers, the biomarkers improved. And very similarly, Redwood for aficamten had a similar study, and they also, in a phase 2 study, showed that patients also with non-obstructive HCM appear to approve of their study, but both of these need phase 3 larger randomized trials. So now I'm going to switch gears just a little bit and talk about something that's totally a new kid on the block, and this is called ninirafaxstat. It's a novel cardiac mitotrope, so not a myosin inhibitor. And this was studied in patients with symptomatic non-obstructive HCM, and it was presented at ACC this year. So there's a theory in HCM that essentially abnormal energetic cost of contraction and relaxation is much higher in these individuals, so you use more ATP. And so this drug is actually very similar to an anti-anginal called trimetazidine, TMZ, which is an anti-anginal that's used mostly in Eastern Europe. And the idea is that this shifts metabolism away from fatty acids to glucose, and this improves basically the efficiency of ATP production. So entirely unrelated to the myosin inhibitor mechanism, but basically targeting a different pathway in HCM that we think may improve symptoms. This was a phase 2 trial, double-blinded RCT, where the patients were randomized to the drug or a placebo, and they looked at mostly what we consider softer endpoints to demonstrate that there is a chance of it showing efficacy in a larger trial. Again, very similar population characteristics to the patients in the myosin inhibitor trials. What this study showed was that there were similar rates actually of serious adverse events in both groups, so it appears safe, but it was not really associated with a change in LV ejection fraction, blood pressure, or heart rate, and there was no significant difference in the quality of life measure. But when you look at the individuals who came into the study with a greater burden of symptoms, those individuals seem to benefit more, which is an interesting observation. And then when you look at this outcome, which is ventilatory efficiency, it also appears to be better in individuals who are given this drug. And this is similar, showing again for the ventilatory efficiency, patients who had more symptoms actually did better, which is always a nice thing actually to see with some of these medications. So what I'll say about ninirafaxstat is it's a very preliminary study. It's only phase 2. There is a phase 3. I know some sites in Canada have already been approached to join the phase 3 study. So it's great that we have now maybe 2 mechanisms that we can really target in an efficient manner in HCM, and I think this drug does show potential promise as well. So just to resolve the case that I brought up at the beginning, so this patient was actually part of one of these trials, and he was started on a cardiac myosin inhibitor. He had a significant drop in his exercise gradient down to 30 millimeters of mercury. He becomes NYHA class 1, and I think what's really important is it just illustrates the incredible improvement in quality of life that he had. So his hemoglobin A1C improved, so his diabetes got better. He returns to like the normal life activities that he should do as a father, and I think he was very grateful to be on this drug, and so for some patients, it really makes a huge difference. So in conclusion, HCM is arrhythmogenic, it causes obstructive symptoms, and it can cause heart failure, and it is directly related to the force of myocardial contraction. And cardiac myosin inhibitors and this novel cardiac mitotrope directly get at that mechanism, unlike beta blockers and calcium channel blockers, which we've traditionally used for the last 50 years. And so in terms of some important future directions, so there is, a greater role potentially for cardiac myosin inhibitors in other types of phenotypes of HCM. And also the cardiac mitotrope, as I mentioned, is going to undergo a phase 3 trial at this point. So I am under time, so I've achieved my main objective, so I'll stop there. Thanks very much, everyone.
Thank you, Thomas, for the timely presentation. Anyone has questions? Please.
Can you hear me? Yeah. My question is, particularly with the mavacamten, is there a point where people stop participating in that clinical trial and therefore are cut off from the medication? Or if they've shown significant progress, do they stay on that medication?
Yeah, so great question. So I'll also say my co-panelists are also HCM experts, so I'm sure that they can address some of these questions too, and we can have a good discussion. But I think there's very small, what we would call dropout during both trials, so people stopping either placebo or the study drug. And in these trials, all patients who agree to participate and are generous enough to participate in research, they are usually continued on these medications as part of a long-term extension study. So it's not cut off when they're finished. They have the opportunity in the placebo group and in the treatment group to then go on and take the medication long-term. And there are great long-term extension studies as well in all of these medications. One day we're going to have 5, 10, 15-year outcome studies. So that's a super important part of this research as well. And for the most part in these trials, patients are not, quote, cut off afterwards. They get to be on the drug long-term if they want to be.
Thomas, maybe to take your question from this morning and turn it back on you, with all the fibrosis and myocardial disarray that's in HCM, do we know with these novel therapies, do we have any longevity on actually reducing arrhythmic death in the populations? It's been very sort of plumbing focused and EF focused, but.
Yeah, so I think that is a very insightful question from an electrophysiologist. I mean, we're very worried about sudden cardiac death in this group, and I think sudden cardiac death is a huge consideration in HCM patients. But actually, the dominance issues in HCM tend not to be as much sudden cardiac death. It much more is a quality of life and symptom-related condition. So I think there are studies looking at arrhythmic risk for the long-term extension study, but to try and design a randomized controlled trial of a condition where the outcome you're looking at is so uncommon, your population size has to be so large to show a difference. So as far as I know, and I know we have industry in the room too, they can correct me if I'm wrong, I don't think there are any planned studies looking at sudden cardiac death risk with the myosin inhibitors simply because the number of patients you have to accrue to demonstrate the efficacy of that is low. But I would think it's very conceivable that it does reduce other issues. I just can't say that definitively.
I'll ask a question. So the mouse studies, like it's been amazing how quickly myosin ATPase inhibitors have come to the clinic. I think it's an amazing story in science. The mouse studies, if mavacamten's given before they developed HCM, the mice didn't develop HCM, and it also caused regression. So do you guys think it's like, it obviously helps with obstruction. Do you think it may be disease modifying? And are there clues at this point in terms of what's we have for human data at this point?
Jason, I think your questions are always a little too high level and sophisticated for me sometimes. I don't know the answers to that. I think maybe, but maybe the panelists that I'm with here have some thoughts too.
What do you think? Yeah.
Well, there's a very small subset of Explorer that looked at MRI, and there seems to be regression of maximum wall thickness. It's a very small subset and clearly a bit early, but there is hope that will be the case. Certainly, giving mavacamten to patients that are phenotype negative is something we may never do, but we're not close to that. Interestingly, I imagine the group here is more interested in ECGs than echocardiograms. So as you know, in HCM, you can have pretty remarkable depolarization abnormalities even before you develop phenotype or with very mild phenotype. And interestingly, with mavacamten, you can have no change in maximum wall thickness with mavacamten, but resolution of the LVOT obstruction and also resolution of the repolarization abnormalities. You can see a patient with really a very remarkable ECG, and a few months later, it looks completely normal. If any of the ECG experts here has any idea what the mechanism behind that is, I would be very much interested to hear.
So I think you answered one of the questions I was raising. Taking from that sudden death standpoint, if you look at patients who don't have obstruction, right? So they don't have, we have patients who are otherwise feel fine, but they're walking around with this risk of sudden death. You mentioned this subgroup that had MRIs. So are there any thoughts of using MRI LGE as a possible surrogate to look at that? And then the second part is the other arrhythmia these patients have is AFib, right? And so is there any plan for, or are you aware of any long-term plan to monitor that? Because these patients are actually pretty hard to ablate and they keep getting recurrences.
Yeah, I don't know exactly what's coming down the pike when it comes to those things. I'm sure that there are going to be sub-studies from the long-term extension study looking at that. There is actually some weak signal that people are concerned about actually increased risk of AFib with mavacamten. I personally haven't seen it, but I've seen a few editorials and things about it lately. So I think most of those answers will come out of the long-term extension studies as you know, exploratory issues. But I think certainly important. I don't know if either of you have come across those studies.
Okay, so I also don't know what's coming, but I agree that it would be a fantastic surrogate. I'm LGE, anything else, I'm interested also in nuclear medicine, like microvascular dysfunction using PET, which I think that it's very prevalent in this population and could be a very interesting surrogate to use. But I don't know if there's anything in the pipeline.
There is an MRI focus study that is enrolling. So we'll know more about MRI, I guess, in a couple of years. With atrial fibrillation, these trials did not recruit patients with new onset atrial fibrillation the past 6 months, if I remember correctly, in order not to cloud anything. So we really don't know. But again, as Thomas said, there may be a signal. Maybe it's just statistical quirks. So.
Just to comment on the disease modification question, in support of the observation that ECGs, the repolarization on ECGs seems to be normalizing. In the paper that Thomas referenced from Science with Green as the first author, they did actually publish in the non-clinical models substantial changes in gene expression in the HCM models on mavacamten. So it wouldn't be surprising to see that there's extensive remodeling. And I don't know what kind of human data will eventually support that, but it'd be very interesting to see.
Okay, thank you very much, Jason. Next.